Okay, very warm welcome and good evening to all the guests who have joined live for this webinar. So let me introduce myself. I'm Deepak Chopra from Women's Healthcare Business and Buyer. So along with me welcoming you, I would like to, initially thank you, all the healthcare providers, especially doctors, so that, you understand how do we respect you, salute you, because like the world is locked out, we all are at home, and this is courtesy your commitment in the front line. So we salute your commitment, doctors, for helping us say that we are fine. So thank you once again so much for this gesture of yours. So what we'll do is this is the first webinar of the two we had planned. So we thought we will not just only talk about the disease or the endometriosis as such. We will have some value add, some credentials, some evidence-based protocols for our practice. So this vision document was evolved last year under Dr. Nandita's presidentship of Foxy. So we initiated last year in the month of February, and it was like more than five meetings all across the country with more than 230 thought leaders, all gynecologists involved to create this. So as far as we are concerned as Buyer, so our purpose is science for a better life. We are a life science company as such, and not only we just treat human beings through our healthcare business, but also like we are a very big player in the crop science segment. So we take care of crop sciences also and life of crops also. Hence, we are a very prominent partner with the United Nations to develop our sustainable development goals as such. So Bayer being more than 150 years old company, so we are also like always very keen and very agile in collaboration in both these segments. As far as our women's healthcare business goes, like we are a global leader. Since 1928, we started with our research and innovation as far as our women's healthcare products are concerned. So that talks volumes about our heritage, our innovation, and of course, our quality brands. You all are aware of our brands which are available in India. Just to brief you, like, in India particularly, Bayer has been nominated as a best workplace for women, not only once, but couple of years. And we run a lot of our social responsibility centric which are women centric. So truly a global women's healthcare organization. So with changing times and with advancement of technology, like we are also trying to catch up with new advancement. So apart from talking to doctors, promoting our brands, we also have a lot of tools and initiatives for our patients, like which indirectly probably is a value add to your patients. So, and you can rely on Bayer for a lot of information and credible information. So having said that, we initiated a couple of digital tools this January. We had Dr. Naren Malhotra. I'm sure you're able to see in that clips, Hindi newspaper clips, along with Dr. Nozer. So we had this opportunity to inaugurate a couple of our digital platform. One was on contraception. We call it a chatbot called Ask Tanu, and second is this app, and we have named this as Bear Your Pain app. Bear Your Pain is on endometriosis, and whatever we have learned from you speaking in so many symposiums and platforms, endometriosis is not a very easy disease to diagnose and treat. So I'm not going into much of details, which will be like, we'll be listening to you all experts. But as I estimate, there are more than 26 million women who suffer from endometriosis in India. So not a easy disease. Hence, we thought this will be something, a good platform for at least women in India to empower them with credible information. And also, basically, so this is the flow of the app, what I'm just trying to take you through. And you can also propagate among your patients. So it is the disease education what we are talking. And this platform becomes like a gateway for the patient to be referred to the physicians like you. And the second, what I was speaking about was on contraception. This is a Ask Tanu chatbot. So respecting the, kind of intimate conversation a female would wish to have especially in India on contraception. So this chatbot again will be facilitating for more credible information and again directing you towards the right physician. So Vizan, which is our brand for endometriosis, Dynogist. So we have a lot of value add to this by at least running a program called a patient adherence program. Vizan values you. So that, like, it is apart from affordability, is accessibility and compliance, so that the patient adheres to the therapy, because it is considered to be a chronic disease, and the patient needs to have the treatment for a longer period. So in a very small span of few months, like, we are able to enroll more than 1,500 patients on this program. So we'll request you, each one of you, to have notice of this, so that more and more of your patients get this benefit. So today, in collaboration with the Endometriosis Society and Foxy, so we have this again a digital version of Vision, what I spoke about, protocol for practice for endometriosis. So this is the snapshot. We had this first meeting in Mumbai almost a year back, 19th of February to be precise. And as I mentioned, Dr. Nandita was the thought behind this, and she only steered this whole idea, and we tried to give a shape to this idea. And probably, as far as our definition goes, probably it was a very popular and very successful program. So these are the names of thought leaders who were a part of it. So we had this whole meeting in 4 parts, right from diagnosis, medical management, surgical management, and fertility issues. So hence we speak this disease to be very, very enigmatic in nature. So we plan 2 versions of this webinar. Today is the first one, and it is medical management of endometriosis, followed by again surgical management, which will be held on the 16th of April. So these are the speakers, eminent speakers. Today we have Dr. Naren Malhotra, Dr. Nandita herself, Dr. Asha Rao, who is the president, chairperson of the Endometriosis Society committee of in Foxy, and yes, our own Dr. Basam Mukherjee. So welcome all the panelists, all the doctors, and hopefully all the audience will be having a great time, very insightful time. So we wanted to differentiate, because as we were talking pre this meeting, doctors have been bombarded with so many webinars on various issues. So we thought we'll kind of try to differentiate ourselves, and I'm sure with the kind of experts we have today, probably you have a amazing experience. And the second meeting on 16th, you have on the screen the name of all the doyens who will be part of our panel. So with this, I will try to introduce Dr. Asha Rao. I told she is chairperson of Endometriosis Committee in Foxy. And just to briefly introduce Dr. Asha Rao, she has been, director of Rao Hospital and Care, Coimbatore. And she is the past president of Coimbatore Obs and Gynae Society, recipient of President of India Gold Medal during her post-graduation in gynecology. And of course, she has been organizing a lot of congresses like IAG, Star Endogyne Conclave in 2019. With this, ma'am, I have a privilege to hand over the session to you. And thank you so much. Thanks each and every person who is on the air as of now. Thank you so much. Thanks from Bayer. Over to you, ma'am. So with this, stay safe, stay healthy, and of course, stay at home. So this is our head office in Thane in Mumbai from Bayer. Thanks a lot.
Yeah. Thank you, Dr. Deepak Chopra, for those kind words. Good afternoon, all my dear friends. It's very nice to see many of you here today, as all of us are locked up in our houses, trapped listening to so much of Corona news. It is a very nice change to have something educative. And I congratulate the Vision Committee for having brought this wonderful program along with Endometriosis Committee. As the chairperson of Endometriosis Committee, it gives me great pleasure to welcome the galaxy of speakers to this program on Endometriosis Committee. Endometriosis is a disease which is more than 150 years old. Yet, there are so many different theories of etiology, difficulties in diagnosis, and disputes in management. This year, our motto is Think Endometriosis and Fight Endometriosis. And today's topic is endometriosis medical management. And we have Dr. Nandita Palshetkar, Professor in Obstetrics and Gynecology, D.Y. Patil Medical College. Gorgeous, beloved Nandita was the president of FOXI 2019, and she was also the president of IAGE. She is the vice president of ISAR. She has been the director at 9 Bloom IVF centers, Lilavati Hospital, D.Y. Patil Bloom Center, Fortis Bloom IVF Center, Sakra Hospital, Bangalore, etc., etc. She is the president of EMOX 2020-2022. And we have illustrious Professor Narendra Malhotra, Managing Director, Global Rainbow Healthcare. And he is expert in ultrasound, laparoscopy, infertility, ART, you name it. He is the best at that. He's the member and fellow of many Indian and international organizations, awarded very many, his very many papers have been recognized. He does not need further, he has been the FOXI president in 2008. He has been the president of ISAR. I'm sure he is going to tell us a lot about the topic of medical management of endometriosis. There are so many interesting aspects he can enlighten us with. Then we have Dr. Basap Mukherjee, young dashing gynecologist from Kolkata. He's a FIGO coordinator for South Asia Safe Abortion Committee, clinical examiner for RCOG examinations in India, member of Governing Council of ICOG, Honorary Secretary, Bengal Obstetric Gynec Society, etc., etc. Without taking further time, let me welcome our speaker of the day, Professor Narendra Malhotra, to address us on medical management in endometriosis. Over to you, Dr. Narendra. Can you hear me? Yeah.
Hello, Brijesh.
Okay, thank you, Dr. Asha Rao, for those kind words of introduction. I've been asked to talk to you on medical management of endometriosis, and I'll try to do justice in the 15 minutes I have. Endometriosis, as you all know, is a very complex and challenging and very elusive disease. How do we define it? It's a non-neoplastic growth pattern of an endometrium, which is outside the uterus, which is similar to the endometrium and invasive but not neoplastic. And it was Simpson who said it is a retrograde menstruation theory which holds, and that still holds good, because once the menstrual blood goes inside, there is an antigenic exposure, and that leads to subsequent formation, inflammation, and the endometrium. I'm not going to go into the detail. It causes inflammation, bystander cells, sensitizing of normal antigens, and an immunological suppression, and that tissue persists inside and starts growing outside. So you have the utopic endometrium and the peritoneal endometrium, which is a little bit different in response to the estrogen and progesterone of the human body. And why it is different? Because there are progesterone receptors A and progesterone receptors B. And in the healthy endometrium, it is the progesterone receptors B which are more, while in the utopic and the ectopic endometrium, it's the A. So that A receptors, if they overpower, then they cause increased cell proliferation
impaired deserialization, reduced apoptosis, reduced anti-inflammatory effect, and hence cause increased bleeding, pain, and all the symptoms of endometriosis. All the theories which are there, retrograde menstruation, coelomic, embryonic, transformation, with a genetic factor, flow obstruction, all leads to this inflammation which is occurring there. And once we see when the disease symptom starts, the first consultation usually occurs to a general practitioner 1 year after the symptoms, the patient receives symptoms. And finally, she wastes 6 years after a surgical diagnosis is made. So the average delay in diagnosis is 7 years. And in this middle 6 years, they try all sorts of medical treatment and all sorts of diseases. How do we diagnose? We have non-invasive transvaginal ultrasound. The markers are not used for diagnosis, maybe for prognosis of the treatment. The invasive, of course, the gold standard is laparoscopy, which is there. Who do we suspect to having endometriosis? Those who come with pain, infertility, pelvic mass. It is an epiphenomena. It is like a benign cancer. So how does one treat an epiphenomena or a benign cancer? That's the enigma. And you look at this picture of this lady on Facebook. I never knew how one day would be from the other day and how I will feel. She was in so much pain throughout. Then we had some guidelines on the treatment of endometriosis. Right from 1927, when this disease was discovered, till 2010, various associations have given various guidelines and balanced the medical or the surgical treatment. So we are not very sure, surgery first, medical first, surgery first, medical, surgery, both together, both one after the other, sandwich therapy, whatever that we need to decide. For planning medical treatment, we have to know which group we are targeting. So you could have adolescent, infertility, fertile group, recurrent endometriosis, rectovaginal endometriosis, DIE, which Nandita will show you a case, and pregnancy with endometriosis. Yes, it occurs in pregnancy also. And how do we do a medical treatment? I'm not going to touch infertility and ART. That's a different part. We are going to talk only about medical treatment for pain and for periods and heavy bleeding. So NSAIDs, OCPs, androgenic agents, progestogens, GnRH analogs, antiprogestrogens, levonorgestrel IUCD, newer experimental drugs is what is there. The first line of treatment which we do is after painkillers and NSAIDs is we try OCPs and we try the oral progestrogens, the new one, the Dynogest. Now this becomes the first line, and probably now the OCP will come after Dynogest, and we'll discuss that in a few slides very soon. Why? Because we want to introduce hypoestrogenemia and we want to antagonize the estrogen action on the endometrium. The second line of drugs which was used was danazol, which is a big no now. GnRH agonist, yes, they work for some time, and the others, which we'll talk about. So when we look at all of them, see the OCPs, the medroxy, the Dynogest, the danazol, and we look at how they work, and we look at how the adverse effects are. Now these are theoretical things which can be read, and we will also circulate this presentation to all of you. So OCPs, low dose estrogen with desogestrel would be the best. But despite of OCPs, some patients do complain. And if there is no relief in symptoms in the first 3 months, then you need to change the treatment. So OCPs have a problem because of the estrogen content. Danazol not used at all now because firstly, we don't use it in the correct dose, and then it has got too much of mesmerizing effect. And we just don't want our women to have a very hoarse voice. So the hoarseness is permanent. So that you have to remember. GnRH agonist, risk of osteopenia, and you cannot give this treatment more than 6 months. So we come to progestogens. Progestogens will be one of the best because they reduce the estrogen, they have an immunomodulatory effect, they have an anti-inflammatory effect, they have a deserialization effect, so causes atrophy of the endometrial tissue. They inhibit the matrix of metalloproteinases in the endometrium, and they have an anti-angiogenic effect. So new blood vessels don't form, and the things work. Do we need a surgical diagnosis before starting progestogen? One group says yes, the other group says a presumptive diagnosis made on symptoms is good enough to start progestogens as the first line of treatment. And what is our aim? Our aim is to treat the symptoms. Our aim is to delay the diagnosis, to reduce the delay in the diagnosis from the 7 years. and our aim is to reduce unnecessary surgeries and repeat surgeries. So we need to, even after surgeries, progestogens should be used after surgery. And the Royal College of Obstetricians say 75% receiving progestogens would do very well when it is considered as first line of treatment, even for suspected endometriosis. The HRA guidelines and the WES guidelines also recommend progestogens gaining popularity for treatment of the symptoms of endometriosis. So Dynogest, the new labeled progestogen, it is labeled. The other progestogens, when they are used, it is an off-label indication for endometriosis. Now here we have a progestogen which is labeled for the treatment of active endometriosis related to pain before surgery and even after surgery. So what is this Dynogest? It's a new drug. It will work on both utopic and ectopic endometrium. On the ectopic endometrium, where we have more worried anti-angiogenic effect, immunomodulatory effect, anti-inflammatory, pro-apoptotic, so it reduces the pain very, very quickly and very fast. It is a structure change of the 19 derivative, and here is a CH2CN atom, an additional double bond here, which makes it unique in action. So which makes it good tolerable, anti-androgenic effects are less, relatively moderate inhibition of the gonadotropin secretion. And it becomes a very, very strong progesterone agent on the endometrium. When you compare it with the others, and as I told you before, the others are off-label treatment, the levonorgestrel, the gestatin, the MPA, the norgestimate, the norethistron, the desogestrel, the cyproterone acetate. And you see that this scores much better in all the activities when we compare the glucocorticoid, the androgenic, the progestogenic, the anti-androgenic, and the anti-mineralocorticoid activities of progesterone. So the mechanism of action is central as well as local. So it makes it even better. And centrally, it will inhibit at the brain level, and locally, it will inhibit work on the endometrium and cause anti-inflammatory changes there. So how it works locally, it will decrease the PRV-PRA ratio, the bad to the good, and it will modulate the estrogen beta and the estrogen R ratios, which has been demonstrated to be changed in endometriosis. So the good progesterone and the bad progesterone and the estrogen receptors being blocked. So Dynogest may help in improving the progesterone resistance, which is seen in endometriosis. And this is a very complex way. So it blocks the NF, it blocks the COX-2, it blocks the local estrogen levels, and it blocks the PG2 secretion, and it blocks the aromatase, and it reduces the prostaglandin E2, and hence causing relief in symptoms. When the studies show that with 2 milligram treatment, relief up to 6 months occurred even when you stop the treatment. So that is the advantage. And with 2 milligrams, significantly reduced the lesion score from 7.8 at week 24. So for 2 years, you see the reduce of the score of endometriosis. And the efficacy in EAPP. Again, you see how over 2 years, Dynogest scores much, much better. And when you compare the lumbar BMD, it is unchanged even in long-term treatment, which we cannot give GnRH for this reason. And when you look at the long-term efficacy and safety over 5 years, studies are over 5 years, and they show that this drug is one of the good effective drugs. So when you compare it with no medication, with GnRH, with OCPs, with Vizan, over a period of 18 months to 5 years, you see here the recurrence rate is only 2.6. So that again is a very promising effect with this. There is a role of estrogen. So when there is a role of estrogen for proliferation in the endometrium, then we need to reduce the estrogen. And that is why when we in the beginning said that when the first line of treatment, instead of using OCPs, even with low dose estrogen, it is preferable that you switch over to using Dynogest rather than estrogen as a first line or OCP as the first line of treatment for endometriosis. And lots and lots of studies show, and lots of levels of estrogen. So the normal levels will be maintained. So hypoestrogenic state is not there. So we have to rethink on the first line of progesterone only rather than COCs, or Dynogest rather than COCs. So that would be one of the things. Now there are some drugs which are emerging, like letrozole, like antagonist, like selective estrogen receptor modulators, like selective ER alpha and beta agonist, and sperms, statins, TNFA, pentoxifylline, anti-angiogenic agents, and dopamine receptor agonists. Now these are all in experimental, and they are still not there for treatment. Aromatase inhibitors, letrozole long-term in research. LX4, most promising, but still research. RU486, GnRH antagonist, TNF alpha inhibitors, and angiogenic agents, immunomodulators, all experimental right now. You hear mifepristone, some of us have used it. Yes, it works for pain, but 6 months, because the problem of hot flushes, fatigue, nausea, liver enzyme changes occur there. IUCD levonorgestrel, very good if there is adenomyosis, works very well in adenomyosis. So to summarize the drug therapy, you have anti-angiogenic agents, GnRH antagonist, OCPs. You have progestogen, anti-inflammatory, progestogens and antagonists. You have estrogen receptor beta ligands, sperms, and you have statins, which are SERMs, which affect work. So this will summarize very nicely what agent you're going to use. Now, medical treatment is effective in reducing the endometriosis pain, but we still cannot eradicate the disease. And once, if there is infertility, if you give medical treatment, the patient will not conceive during that time. So that has to be balanced in whether we're going to give expectant treatment, pharmacological treatment, or surgery, and what is indicated. So here is expectant management, its advantage, pharmacological management, that advantage, surgery, its advantage, and the expectant management, the disease will progress, that's a disadvantage. When you give medical management, it's cause, compliance, and recurrence. And when you have surgery, it's a traumatic surgery, infections, ovarian reserve, adhesions, and surgical recurrence. So that those balance have to be maintained. Of course, some people, the Chinese people, try acupuncture. I'm sure we're not going to follow the Chinese now. So endometriosis, most of the time, is a hit and miss management because of its elusive diagnosis, because of its slow progression, because of the challenging treatment, because prevention is unthinkable, recurrence is frustrating, and elimination is impossible. So we need a team, and the team should be headed by the gynecologist in red, and the surgical team, the pain management team, the psychotherapist, the counselors, the nurses, the psychologists, the nutritionists, a patient support organization, and non-traditional partners. They all should come together if you're going to treat endometriosis. So ladies and gentlemen, he who understands endometriosis knows gynecology. This is what Sir William Osler said. And endometriosis, despite of so much research, will still remain an enigma because it is a kind of a benign cancer. And it is impossible to understand epiphenomena or a benign cancer. I thank you very much for giving me this opportunity for sharing my thoughts on such a difficult topic. Thank you very much.
Thank you, Dr. Naren. It was such a wonderful lecture, such a vast topic. You have concised beautifully. So many doubts have been cleared. I'm sure there will be a lot of questions. I request the audience to put their questions in the chat box so that we can take it up later. Now we go to the case discussions, and I ask Dr. Nandita to take over.
Hi, Dr. Asha, thank you so much. Naren, that was a wonderful talk. I mean, beautifully done. And so simply you've explained all the concepts and all. It was really fantastic. Asha, when you called me for the webinar, I said, oh no, not one more on COVID. And I was so happy when Niranjan told me it's on endometriosis, it's not on COVID. I think we've had an overdose of COVID. And I'm really, really happy today to be talking about something other than COVID. And we are going to begin today. I think we have Asha, we have Narendra, and we have Basa. So Basa, welcome, and we are very happy to start with the first case. Me being in infertility for 25 years, I've got the first case, which is deep infiltrating endometriosis. So, but anyway, I think it's a very good take. It's a very young girl who's 28 years. Can I have my slides? Though I do know the history, so it's okay. So panelists, let's listen to this. She's 28, unmarried, and she is complaining of pain, which is really getting severe day by day, and her work is being affected.
She's going to put it.
Yeah. Who's putting the slides?
I think Nandita, you were supposed to put it, but
I don't have them.
You don't have them. Okay.
Okay,
I think everybody.
I can put it. I can put it now.
Yeah,
yes.
Just put it.
If you can share it then.
Because it's easier for people to follow if,
Yeah, I think Dr. Asha can put all the slides in that case.
Yeah.
Easier, yeah. I think
and Asha, you'll only have to move them, I think, unless you
okay.
control, because I'm not very tech savvy. I don't know how to take the controls from you. Okay. So can you have the next slide, Asha? Can you fast forward it a little?
Yeah.
So this is this girl who has got pain, which is really, really severe. It's all the year around, and it's now more during her periods. And actually, she stays home from work. It's, she's really incapacitated by the pain. She has taken numerous painkillers, and the combined oral contraceptive have not given her much relief. And yes, she's getting married within a year, but she has no plans of children. You know how everybody plans their life. So maybe 2-3 years, she won't have any children. And the ultrasound of the abdomen actually, 1 minute, shows bulky ovaries which are adherent to the uterus in the fundal region. So they're really pulled up, multiple cystic lesions in the bilateral adnexia, pelvic peritoneum causing lesions, surrounding bowel, likely suggestive of peritoneal seeding, possibility of endometriosis, and the MRI findings are also here. One second, let me just move this out. Yeah. The MRI findings are also consistent with deep pelvic endometriosis with peritoneal thickening, with multiple loculated hemorrhagic and non-hemorrhagic collections in the peri-ovarian region, bilaterally suggestive of endometriosis. Multiple adhesions also seen in the abdominopelvic region. Endometriosis are also seen along the serosal surface of the anterior rectum, so the posterior compartment, and also the anterior compartment, that's the posterior superior wall of the urinary bladder, and suggestive of pelvic endometriosis, and also involving the rectal wall and the bladder. So Asha, can I have the next slide? So my question to all of you all is that this is the girl who's come to your clinic, you've done the investigations. Now, what would you advise her? How would you manage her?
She's a young girl and not interested in yet to get married, and not interested in pregnancy. I mean, fertility is not a factor at all. And by all the symptoms and signs, it is definitely pointing at endometriosis. And now with ultrasound, it seems to be a complex disease. With MRI also, it seems to be, it almost sounds like a frozen pelvis. And the diagnosis also shows that there is some lesion around the bladder. The diagnosis is deep infiltrating endometriosis, and she has severe pain. But when fertility is not a problem, we can definitely go in for medical management. Is it surgery or medical management? I would definitely prefer medical management. We can suppress her with progestins, and I would prefer Dynogest.
Before you go on to the medical management, would you like to, she's a young girl, would you like to investigate her ovarian reserve? I think it's very, very relevant at this point.
Yes, I think it will be good to record her ovarian reserve. But whatever is her ovarian reserve now, I think will not make a difference in management. But for the sake of future, I think it will be good to know the ovarian reserve, because we are going to suppress her ovaries. And it is good to do the ovarian reserve anyway.
Yeah, Naren, can you? I hope there's some controversy here.
Actually, it's not about this. We've been asked to just hold on a discussion for 2 minutes because there are a huge lot of people who want to log in just now. And with the slides on, they're not able to log in. So the technical team wants us to hold for just 2 minutes.
Sure.
All those who are hearing, just wait 2 minutes. A lot of people have logged in just now and they're not able to do it just because we have the slide on. So can we just hold on for 2 minutes?
Okay.
Till we get an okay from the Science Integra team.
Switch off the slides.
Yeah.
I don't need the slides now.
No, but somebody had the people who are logging in. Dr. Nandita would like to see them. No?
Okay. All right. Is that Deepak? Is that
So
you?
just for 2 minutes.
You can put the previous slides, Dr. Asha. The previous one.
I'll begin.
The summary. Yeah, this could be kept up. Yeah.
Let this remain on the screen, I think.
Yeah, I think that should be fine. I think, and then we can work.
Otherwise, I think we should play the video tomorrow or day after and put it on.
Sir, I have the video of buyer. So if you allow, I can just share my screen and play the video.
So I don't know what they want. They want us to be completely off for 2 minutes, I think.
Until the problem gets resolved, at least the viewer who are watching live can just see the video.
Yeah. So Subbu, can we do that? Is Subbu on?
Yeah,
Or you want us to be completely off?
No, sir. We can be there. I think Subbu.
I think Subbu wants us to talk to the people when they all come in. So probably the Bayer video should not cause a problem.
The people who are already there can be part of the discussion if everybody agrees. I'm not.
At least people who are there, you can put your questions and we can have them in the chat box and let's do the writing instead of answering.
Okay, but listen, let's. Naren, I wanted to know, Asha was saying we do the ovarian reserve, but it does not matter whatever.
No, it does not matter at this stage. I think we need to.
No, I don't agree with you. Basab, do you have an opinion? Otherwise,
I have an opinion, Dr. Nandita. I think that it will matter only if you're doing a surgical procedure on her.
Yes.
If you're not doing a surgical procedure at this point of time, I would not do an ovarian reserve on her.
Okay, can I tell you why I think otherwise? I think the ovarian reserve is very important because she's 28, severe endometriosis, and we know that endometriosis affects the ovarian reserve of young girls. So it's very important to know, because if it's normal, fine, we don't do anything, we give medical therapy as Asha has said. But if it is low, then I think you need to monitor it, or you need to offer her
to give the go ahead for them
fertility
to talk
preservation.
the moment you know that.
It's very, very important, I feel, especially in this kind of where you're expecting a frozen pelvis in this young girl, and she doesn't want to have a child for the next 2 or 3 years. So you need to think out of the box. I mean, this is something which you should offer to that young girl. That's what I feel.
I think, Dr. Asha, one thing I think which you had mentioned here, the first thing is the option of medicine versus surgery. And I think the importance is to discuss with her the options. Dr. Narendra has very clearly shown in his slides that the biggest concern of this lady now is pain. She has severe pain, and pain relief is her priority number one. So the question is, how much of pain relief can we give her using Dynogest maybe twice daily for a couple of months? Dr. Asha, if you'd like to put that, then we would balance it and then possibly go ahead with surgery if medicine doesn't work. What about GnRH analogs? Can we give her a couple of shots?
No, before you go, Basab, how long can you continue the Dynogest? That's what I would like to know.
Dynogest can be given for up to 2 years.
2 years? No, I think 5 years was the new trial.
Because I showed you the slide of 5 years also.
Yes.
For 2 years very safely without any problem.
Yes.
Yeah. What are the problems that you face and how should you overcome them? What are the problems with Dynogest that you're seeing?
The problem is, in this case, Dr. Nandita, I don't think she will respond well to Dynogest. She will probably need an early surgical to get those adhesions off, to get the because if it is DIE, the DIE is the worst to treat by medical. She is going to be a medical treatment failure after maybe 6 months or one year. So even if we give her GnRH 6 months and then put her on 2 years of Dynogest, maybe the pain will go off for 8 or 9 months. After that, it's going to come back. So we have to think of surgery in this.
Play the next slide, Asha.
Yes, I'm already on
the next slide.
No, that is the treatment plan.
So that is what Naren is talking about. Can you get that slide in? Yeah. That's what Naren you're talking about, that we do a laparoscopic surgery followed by a medical therapy.
Correct.
And I think that is what is really, really important, because as you said, for DIE, the medical therapy will work better post to prevent a recurrence. And that is what is important. So could you little bit, any of you, could you elaborate on the treatment, what you would give during the surgical? What are the surgical nuances that you would, would you have a team? Would you have a surgeon, colorectal surgeon with you?
See, if it is DIE and you're sure that it is going into the rectum,
Yes.
obviously you have to be prepared for colon, that area resection. So colorectal surgery.
What is the thing?
Is absolute.
I think it might be important to do a transrectal ultrasound and see what kind of nodule we have.
Yes, yes.
And assess the problem. And she will require very thorough counseling, because it requires a multidisciplinary approach. And definitely we need sometimes consent for colostomy, because if we get into a problem, later the patient will never excuse us. So it's very important to discuss the possibility of injuries, even in the best hands. That's exactly why many doctors who are perhaps not the best surgeons, for a young girl like this, perhaps might still consider medical management first. And if she's not better, then only go in for a surgical management. And just like Nandita discussed, it is important to discuss her AMH. And if AMH is on the lesser side, without waiting for a long time, whether she should even, once she's better symptomatically, whether she even consider egg freezing if she can afford it, and if she wants to wait for a long time.
I think only one question I wanted to ask all of you all. So you all are very clear that you would prefer surgical therapy followed by medical.
I'm not clear. I'm not clear. I'll give her the option. I'll talk to her about the things which you can do, because her priority one is pain relief and medicine. If she agrees to having medicine, a trial for 3 months to 6 months, then only I'll be offering her. Otherwise, you'll go in for surgery straight with all the precautions as Dr. Asha has mentioned. But it's not to go in with guns blazing for surgery.
Oral contraceptive pill. So after that, you still want to give her 3 months of Dynogest?
Or GNRH analogs to see whether it's making a difference. Like, she may not want the surgery. She may want pain relief. What do you do in that case?
See, Dynogest, you can give it for 5 years. But GNRH analog, how long would you give it?
So we can discuss with her, like, let's see what she wants. So often the parents would not like her to have a surgery before marriage, and all those issues are there. So let's discuss, if you can discuss it with her and she opts for a medical treatment or a trial of a medical treatment for 3 months, we can always see how it goes. Of course, the endometriosis won't dissolve. And as Dr. Narendra has said, that DIE doesn't respond to medical treatment very well. The chances are that she may have a surgery later, but a surgery now versus a surgery 3 months later is her choice. And I think it may happen anyway.
Agree with you. You try medical, then do surgery, and then put her on medical. So it's like sandwich the surgery in between 2 medical treatments.
There are 2 aspects here. One is pain and the next one is fertility. Just now, the pain is a problem. So let us suppress her with whichever is the best for her, Dynogest or GNRH analog for one year at least. Later she can be put on. I would prefer to start with GNRH analog at least for 6 months, and later put her on Dynogest for maybe 1 or 2 years. And to everybody's surprise, there are women when they try to get pregnant, they are pregnant. We never know, because ovulation can take place. Tube might still be open somewhere. And to everybody's surprise, we have seen women getting pregnant in spite of disease like grade 3 or grade 4 endometriosis. So I feel that instead of going for surgery, we should go for management.
But Dr. Nandita, how would AMH change your management? Suppose our AMH is low and you're not planning surgery. How would you manage?
See, if the AMH is low, I would discuss fertility preservation with her. And with the fact that it is just a fertility insurance, she may or may not need those eggs in future. She may conceive naturally, as Asha has said, with the good surgery, she may be able to conceive naturally. But studies, in fact, in the 2018 journal, it has showed the fertility sterility studies have shown that if you operate and then give them for IVF or even allow for normal conception, it's much, much better. So I think, the fertility question should be discussed with her at this point. And also, I feel rather than GnRH analog, Dynogest is a better option. For the woman, there are less side effects, hot flushes, etc., the bone health and all that we're concerned about. So in this case, I feel your medical therapy, I agree with you, Basab, that medical therapy would be a good idea. If it doesn't work, then we go for surgical and then medical, if at all.
I would like to request you all not to get panic. Do the 5. Practice social distancing. Follow hand hygiene. Follow respiratory hygiene. Avoid touching your face. Keep a distance of minimum 1 meter with others. Know the symptoms of COVID-19 infection. Use personal protective equipment when required. And most importantly, follow recommendations of Government of India, WHO and FOXI, and stay safe, stay healthy and stay at home.
అందరూ ఆరోగ్యంగా ఉండండి, జాగ్రత్తగా ఉండండి, మీ ఇంట్లోనే ఉండండి, కరోనాని తరిమి కొట్టండి.
स्वस्थ रहे, सुरक्षित रहे and please घर में रहे.
स्वस्थ रहे, सुरक्षित रहे और घर में रहे.
ಆರೋಗ್ಯವಾಗಿರಿ, ಸುರಕ್ಷಿತವಾಗಿರಿ, ದಯವಿಟ್ಟು ಮನೆಯಲ್ಲಿ ಇರಿ.
ஆரோக்கியமா இருங்க, பத்திரமா இருங்க, அவரவர் இல்லங்களிலேயே தனிமையா இருங்க.
নিজকি উষ্ঠা আৰু সুৰক্ষিত কৰি ৰাখিবলৈ ঘৰত থাকো.
स्वस्थ रहो, अपने अपने घरा में बढ़ा रहो, बाहर मत निकलियो और अपनी अपनी सेहत का ध्यान रखना, सुरक्षित रहो.
Stay healthy, stay safe and just stay at home.
निरोगी रहा, सुरक्षित रहा आणि फक्त घरीच राहा.
सुरक्षित रहो, स्वस्थ रहो आणि घरे रहो.
स्वस्थ रहो, सुरक्षित रहो और घर में ही रहो.
স্বাস্থ্যকর থাকুন, নিরাপদ থাকুন এবং কেবল ঘরেই থাকুন.
सुरक्षित रहंतु, फिट रहंतु, घरे रहंतु.
घर रबती, सुरक्षित रबती आणि फिट रबती.
सुरक्षित रहे, स्वस्थ रहे और अपने घर में रहे.
घरी रहा, सुरक्षित रहा, गर्दी टाळा, आरोग्य जपा.
The health and well-being of people have always been a priority at Bayer. In the present pandemic situation, we acknowledge and appreciate the relentless efforts of medical fraternity to deal with this health crisis. Stay safe, stay healthy.
Today, as most of us are trying to be socially responsible and staying at home, the doctors and the medical staff are playing the most crucial role of being out there in the front line in dealing with the COVID-19 situation. Bayer salutes their commitment for rising up to the occasion and going beyond the call of duty. Stay safe, stay healthy.
In the chat box, there are already questions which you can take.
Yeah, let's take those or the case by Basal.
Cases or what is happening now? I mean,
Dr. Asha to guide.
I think it's the next is Asha's question.
Yeah, Asha.
Asha's case presentation. Let's finish this because we've already talked how Dynogest would be the best in this case scenario with less side effects than all.
Dr. Asha has to unmute. Yes. Dr. Asha, you have to unmute.
Please unmute. Subbu, can you unmute her?
No, you can't, I think.
Is it okay now?
Yeah.
Yes.
Now it's okay.
Yeah, okay. Sorry, there was a bit of delay. So, the second case, 36-year-old woman presented to infertility clinic. With a partner. Patients reported that menstruation progressively became heavier, more painful over past 3 years. Recently, she had started having severe pain at the time of ovulation and with deep penetration during intercourse, especially immediately prior to menstruation. Radiologic evaluation indicated presence of endometrioma of 4.5 centimeter. Couple married since past 5 years, regular unprotected intercourse, husband's sperm parameters normal, and a postcoital test was normal. Unsuccessful 5 attempts at IUI. Laparoscopy and hysteroscopy performed 4 years back, which did not reveal any evidence of uterine or pelvic pathology. So, who will take it up first?
All of us will be able to. Dr. Basar has to go, I think.
Dr. Basar?
Yeah. So, so what do we think? So we think, like as you said, it may be an endometrioma. The radiological evidence.
So by ultrasound, she has a 4.5 centimeter endometrioma.
Yeah. But I think we didn't discuss this, but I think it's important when we talk about endometriosis and the person who's doing the sonography, as long as he or she has a knowledge of endometriosis disease and gets a detailed history and knows what to look for, you may often miss additions and the ways our endometriosis would possibly look. An endometrioma is easier to diagnose, but additions are not. So unless you really know what to exactly to look for. So if they're thinking that it is endometrioma and it is endometriosis, which she has developed now, then that changes the discussion. And then the idea would be to correct it and treat it and go ahead. So now whether to have a laparoscopy repeat, because 4 years ago when she had it, she would not have had the disease. The disease is something positively new that she's having it. Whether you need to treat the disease and go ahead. Again, now the AMH picture comes in, like Dr. Nandita had mentioned in the previous case. I would definitely do an AMH before considering a laparoscopy or possibly giving her other treatment. She's had 5 IUIs. The next obviously would be IVF. But let us, again, I'll discuss with her. I'll check an AMH and then decide. A 4.5 centimeter endometrioma, as I understand, will not interfere with IVF. That is definitely one option. But Dr. Nandita would be in a better position to answer this question than me.
And at the same time, the ultrasound did not show any hydrosalpinx or serious additions and no adenomyosis.
See, personally, I would go straight for IVF in this patient because she's 36, had multiple IUI failures. So I would rather do her AMH and go for IVF in her case. Now, there's a lot of controversy whether to do surgery or whether to do IVF first. See, if there is a longer duration of marriage and other treatments have failed, then I would go for IVF. But if she was a younger girl, say between her 30s to 35, then surgical therapy, because within 12 months of surgical therapy, the pregnancy rates are equally good. So it all depends on the AMH. If the AMH is good, and this is not a case of recurrent surgery. In fact, it's a very interesting case because you've not touched the ovary in the prior laparoscopy at all. So actually, even if you operate, it will be a primary surgery on the ovary. So you can treat it as a primary surgery rather than a recurrent endometriotic surgery, which is supposed to be not repeated at all. So, but because she's 36, I would like to do IVF on her.
If her AMH is 3.5 and if she has 6 to 8 follicles on either side, what would you say? Can you put a trial of laparoscopic surgery.
We clearly have.
One ovary is normal. One ovary is normal. The other ovary is involved.
So we have only two choices here.
Yeah.
The age and AMH, of course, will decide. Medical treatment is out in this case because medical treatment will delay her fertility. So number one is out. No medical treatment here, except for suppression pre-IVF if we are going to do the long protocol. Surgery, yes, that's an option. If she was 34 or maybe 33, I would have gone for surgery first. She's 36, on the borderline, 5 IUIs failed. My first choice would be IVF, even though I'm more of a laparoscopic guy.
You know, we are all IVF specialists here, but if there was an endoscopic surgeon, he would go for surgery.
I'm an endoscopic surgeon. My wife is an IVF. So there's a big debate between her and me on this case.
I feel that you have to counsel her.
It should be IVF.
Counseling her is very important. That by doing surgery, perhaps there will be loss of ovarian tissue, reduction in AMH, and a reduction in the number of eggs that you can get after surgery. So we have to tell her the side effects of surgery. If she insists on surgery and if she signs for it, saying that, no, I want surgery, then perhaps you should give her a chance. And if at all you're doing cystectomy, what care will you take, Dr. Naren?
Pardon, if I'm doing cystectomy?
Yes. What are the precautions and what are the points that you would observe?
Obviously, we have to cause the least damage to the ovary, so less cautery, doing it very carefully, trying to enucleate the whole thing, because if you leave that cystic wall, it's going to come back again in a few months or maybe a year in your stimulation. So surgical precautions for endometriomas are very clear, very well defined, and they all have to be followed meticulously. So a meticulous surgery, not everyone should do endometrioma surgeries. Only those who are experienced in endometriosis surgery should do endometriosis. So an above average endoscopic surgeon should be handling her, not even an average endoscopic surgeon. And
you can also look at
the ovary has to be, the use of cautery has to be minimum.
Yeah, thank you. And we can also consider the endometriosis fertility index. How good that start? Okay. So, and maybe we can give her 1 or 2 cycles of IUI post-operatively. What do you suggest?
Yeah, if we do a good knee surgery and if there are no pelvic adhesions, no other peritoneal factor, and it was only a clear-cut single endometrioma, yes, then maybe 2 cycles more of IUI. Otherwise, if there were adhesions and pelvic factor, then please no. Then again,
no further delay.
Naren, I want to see if she had no pelvic factor and she's already done IUIs and she's not conceived. I think it's time to move on. If she had
my first choice is IVF only, Nandita.
Yeah, this was to keep the patient happy because she insisted on surgery. So
if you correct her pelvic,
bad luck, she did not conceive. So now we are going in for IVF.
Yeah.
And no too much delay. And if you are going for IVF, how would you go about Dr. Nandita?
I would prefer to give her an antagonist protocol and collect the eggs. And it's very important to understand that endometriosis has an effect even on the endometrium. So the endometrium needs to be corrected. So I would collect the embryos, freeze them, and then give her a GnRH analog for 2 cycles, which will help me correct the endometrium and make it pro-implantation, and then put it in. And believe me, with young patients, 30 to 35, even with 1 embryo with GnRH analog, you've got fantastic results we've had. So this patient has an AMH which is 36. She will definitely go home with her own genetic child. So it would be worth giving her an GnRH analog before the frozen thaw cycle, definitely.
So wonderful, Dr. Nandita. You would like to do the antagonist cycle, and then you would like to suppress for 2 to 3 cycles, and then you would like to do the frozen embryo transfer. Any difference of opinion, Dr. Naren?
No, I agree with her.
And what would be the place for, in case she fails this cycle, 1 cycle failed, how would you take her up next?
No, if you have frozen embryos, then you obviously have to tell her that it could be 3 cycles with frozen, one frozen, maybe one frozen.
2 cycles of FET have failed. So how will you go about now?
Repeat her hysteroscopy again. Check it out. You know, if I've had a patient like this where I did medical therapy, did IVF, she didn't get pregnant. I did laparoscopy after 2 failures of FET and then did FET after the laparoscopy. It really worked wonders. So sometimes you may go in for medical therapy. If the patient doesn't conceive, you go in for surgery. But if you've already done surgery, then I think you should give her 3 or 4 attempts before giving up and saying she's a recurrent implantation failure. And then, of course, all the gamut of other investigations starts. You know, you investigate her uterus by doing a hysteroscopy. And one thing I want to add here, Asha, is that when you are doing a laparoscopy for any patient of endometriosis, please combine it with the hysteroscopy. Don't leave the hysteroscopy out. Whether she's married or not married, it would be worthwhile doing a hysteroscopy on her.
Always, always.
Nandita, if you do a laparoscopy now, what is it for?
No, she's already had laparoscopy. So I'm not saying now. But if I had not done surgery on her, you know, I had given her medical therapy. I mean, just gone for IVF directly without touching that endometrioma. Then yes, there is a role of surgery after 2 failed IVFs. I
think Lady Luck is a crazy woman. Lady Luck is a crazy woman. There are patients who fail by IVF, and after a chocolate cystectomy, after a failed IVF, there are patients who have conceived. I'm sure the surgical team will tell us after 3 days. So now my question is, what is the role for ultra-long suppression in this patient? Ultra-long down regulation.
Yeah, you can do it, but what you need, because of the ultra-long regulation, you need a higher dose of gonadotropins, and we have to. It is very good if you're going to do a fresh embryo transfer, but since now we have this possibility of freezing the embryos and giving GnRH analog, I don't use it anymore. And at 3.5, you have a very high chance she'll hyperstimulate also.
But Naren?
Yeah.
3.5 AMH hyperstimulation can occur with the ultra-long protocol.
She fails with a couple of GnRH antagonist cycles.
And you will be spending more on stimulation.
That you're saying. After the GnRH analog cycles, you're saying.
GnRH antagonist cycles.
I think we're using GnRH analog during the frozen thaw cycles. I don't think it really makes any difference. That's my personal opinion.
Yeah. Okay, so this lady being having good AMH 3.5, and this lady the panelists would prefer to give her a antagonist cycle and do a frozen embryo transfer. Dr. Basam, any opinion from you?
I don't do IVF, so I'll refer to Dr. Nandita, and what Nandita says, I'll agree for now for the next half hour.
Thank you.
Okay. So ART opted promote.
Yeah. But one thing, Dr. Asha, which you mentioned, which Dr. Naren also said, if the surgery is done well, and if there are it's not a frozen pelvis or advanced endometriosis, whether there is a role of 1 or 2 cycles of IUI before going into IVF, if it's AMH. So I think that's a debate.
Already, I said if the endometriosis fertility index is good, there is no harm.
You have an option. You have an option.
Without wasting too much of time.
Without wasting too much time. I think a lot of people will agree.
Sometimes doctors doing 10 IUI cycles. And when all the eggs are exhausted, they are sending the patients for IVF.
That should not happen.
That should not be done at all.
That's not encouraged.
Yeah.
I really don't agree with this. I think the patient is fed up. By the time she's done 5 IUI cycles, she's absolutely fed up. She wants time to pregnancy to be shortened.
No, but I think the surgery has an intervention by itself, and whether that would make a fertility.
It's worth trying if your patient is willing, but she's 36.
I guess you shouldn't waste time, I think, is the message forward. We shouldn't waste time. Whatever you want to do, get it done fast and move to IVF earlier than later.
It's possible that she perhaps had a small chocolate long back which was missed, and repeated IUI would have promoted the chocolate to grow further. That itself could have been one of the reasons for her chocolate cyst. So going for IVF would be much better than wasting a lot of time.
Yeah, because the cumulative endometriosis recurrence rate is much lower with IVF than with IUI stimulation.
If this patient had very few follicles, poor ovarian reserve, and just an AMH of 0.8, what would you advise her?
Meaning before, I would rather go in for egg collection, accumulation, pooling of eggs.
Pooling eggs.
Pooling of embryos is the way we would go with her. Not surgery.
Anybody suggesting donor eggs? If the ovarian reserve is poor and 1 or 2 antagonist cycles are failing,
then yeah, you have to keep the option open to her.
But not straight away. No, straight away you want to do a egg collection and see what is the quality and what is and how many eggs you get. If you don't get and the quality is poor, then of course the next cycle goes to donor.
If I tell her straight away egg donation, she'll go to Naren next.
And that's only the last resort.
Yeah. So we have to give her a chance once at least.
Because patients sometimes are confused. They have even come with a request of surrogacy. There is a lady who said, I have had 2 egg collections, 5 embryo transfers.
Aisha, this is
something wrong. So it's very important to tell the patient that though the egg quality is poor, the endometrium is still good. So if everything has failed with her own eggs, then perhaps you can consider egg donation, not as a first instance.
So we need to have a clear-cut guidelines, and all doing IVF in India should be following the same guidelines. But some clinics would go ahead or even younger patients, they start away with OD. So that practice has to go away.
Yes.
Naren, it depends on the patient's primarily.
Yes.
If the patient wants to try with her own, it's fair enough. And I don't think I agree with Asha about the equality. Most of the younger, it's all age related, I feel.
Pregnancy is age related.
Yeah, quantity is definitely reduced. There's no question about it. But the quality of the eggs are pretty okay, considering today's labs, which are giving better results, better embryos. So the pregnancy rates have really become very good compared to what they were 10 years ago.
A younger woman with lesser eggs has better chance of getting pregnant than an older woman with more eggs.
Hello, and now let me tell you, add a new aspect to it. An older woman, 40 plus woman, if you do PGS on her and the embryo is euploid, then she has the same charge as a 30-year-old. So that's another technology we've got available to us.
Agreed.
Sorry, we are going into depth in a different.
I think you are bringing out.
We have lots of questions, Asha. So I think we should.
Yeah.
There are lots of questions in the chat box.
I know. So let us conclude.
Let's go ahead.
So we are all favoring ART and we are favoring antagonist cycle with frozen embryo transfer for this particular patient.
Correct.
Thank you. Now we go to Dr. Basav's case.
Yeah. Hello. So this is the case of a 27-year-old unmarried woman who presents with complaints of chronic pelvic pain with severe dysmenorrhea and non-cyclic pain since the last 6 months. The pain is sharp, stabbing in nature, and such severe intensity that she is unable to perform her daily routine activities and unable to socialize, especially around her menses. Quality of life has significantly reduced or been affected, let us put it. She's visited multiple physicians, gynecologists, let's put it gastroenterologists also, without any significant improvement. He has had a past history of multiple courses of combined oral contraceptive pills, painkillers during the time or episodes of her problem, and that did not provide her with substantial relief from her pain. She prefers to wait for 2 to 3 more years before getting married. That's not her priority just now. And of course, after that, to try for a pregnancy. On clinical examination, she has non-specific lower abdomen tenderness, pelvic tenderness. Ultrasound and MRI also was done in this case, which does not show any specific finding. A diagnosis, as we are discussing endometriosis today, it would be suspected endometriosis. It possibly could have been a lot of other things, but today it may be a suspected endometriosis. How would we move on from here? Dr. Asha, the next slide would be, I think, a differential diagnosis. Yes. Dr. Naren, would you like to take it? Like, what would be looking at her? She's having severe discomfort and we need to give her relief.
So differential diagnosis could be pelvic or extra pelvic pathologies. Could be anything in the pelvis, other than the uterus and the tubes and the ovaries. Chronic PID would be and chronic pelvic congestion syndrome would be my first two because of the history. And otherwise it could be any non-pelvic disease also. So she has tried COCs, and as I discussed, COC, 30 to 40% of patients may not find relief. And if they do not find relief, we put them on progestogens or put them on GnRH. So if I would put her on a trial of Dynogest or GnRH for 3 months. And if she starts getting relief, keep them on medical treatment. If she does not get relief, it warrants me to do a diagnostic followed by what comes out laparoscopy to correct whatever problem is. So that would be my line of treatment in such a patient.
Like, I agree with you, and I think a lot of us would be doing things in the line what you have mentioned. Dr. Asha, anything different from what we have already discussed?
This lady, not so young, she's 27 years. Once again, definitely do her AMH, whatever her problem is.
Workup has to be done.
It's very important to do the AMH, and with her history, definitely is suggestive of endometriosis. She even has tried some COC, which did not help her. And there is no need to do laparoscopy in this lady. I would definitely like to go in for Dynogest, the way Dr. Naren has told us.
Yeah, Dr. Naren mentioned the laparoscopy as a last resort if medical management does not give her relief, to try to see whether there could be some other cause. Possibly even after she goes to a gastroenterologist, has her endoscopies done, and the other things are ruled out. Dr. Nandita, any inputs from this in this particular?
There was a very beautiful article in between on fertility sterility that it takes 5 to 10 years and 5 gynecologists before the diagnosis of endometriosis is made.
7 years, I showed you in my slide, 7 years.
Yeah, so you need to, think endometriosis and give her the trial of medications. And I totally agree that sometimes you have to be more aggressive. So if the Dynogest doesn't work, you must put in a laparoscope for diagnosis, definitely. And the diagnosis needs to be made early. And that is why I think I must thank Bayer for that vision document and that, even the patient toolkit which they've done, where awareness about endometriosis has been spread a lot, and people should think endometriosis as the first diagnosis.
One question which Dr. Asha has put here.
Papers from Chapron, Bersolini, where the Dynogest is preferred over the combined oral contraceptive pills. She was earlier on COC, perhaps that was not adequate for her. And these patients sometimes can also have continuation of deep infiltrative endometriosis. So she did not respond to COC. Now she may respond to Dynogest.
So all of us are using 2 milligrams per day, right? What I have done is, supposing sometimes there is irregular bleeding and all because of Dynogest, then I up the dose for some time, make it 4 milligrams, and then get back to again 2 milligrams. Yeah. But I think counseling the patient that you can have spotting, you can have irregular periods is very important. But it's a wonderful drug. I've been using it for so many years, and especially on adolescent patients. Young adolescent girls, it really works wonders.
Just one point here. I think it's a different point. Dr. Asha has put this slide up. What are the diagnostic markers to start medical treatment for endometriosis empirically? What she is actually talking about is CA125. I think we should be mentioning it, that it is not a diagnostic marker for endometriosis, and it should not be done, and it does not does not lead your way you are managing. Could be here again. Dr. Asha, would you like to bring that point in? CA125 has no role.
CA125 is not diagnostic at all. And earlier we used to say you can use it for follow-up. I do not believe it in anymore. There is no value for doing CA125. And other markers are being tried, but nothing is there yet. So you have to do empiric treatment only, which is quite justified according to the HRA guidelines also.
Dr. Asha, if you can take us through COCs in managing endometriosis. I think it is often the first line of treatment. All of us do agree that in an age of 15 to 20, possibly you would start with COCs, preferably continuous, but sometimes cyclical initially. And though it has less, it may have an effect initially, which would be the first line of treatment in many cases. But overall, the evidence is low to suggest that COCs is very effective in managing endometriosis.
In the years that we did not have better medication, we used a lot of COC.
That is correct.
Because we had no other choice.
Yes.
So, but today that we have Dynogest, in the last, say 5 years, when I tried Dynogest, we are extremely happy. The patient compliance is much more with Dynogest, and the pain relief also is much better with Dynogest compared to the COC.
What is Dr. Naren trying to show us?
Part of it.
COC is the advantages and disadvantages. So it's probably, it used to be the first line. As I showed you in my slide, I'm just playing that away. We will circulate this. But I think Dynogest should now be the first line, especially adolescents, especially girls like this. And we should give a trial of Dynogest. 3 months. If she improves, 2 years. If she improves more, does not get married, up to 5 years. If she does not improve, put in a scope.
Yes.
Yes.
Very clear.
Dr. Asha, would you like to take the questions in the chat box?
Yeah, now we have a lot of questions. I think, Dr. Asha, you must take each one of them.
Shall we? Yes. So in this young lady who is not interested in fertility, there is no need to do a laparoscopy. You can start empiric treatment, preferably with
Absolutely. Absolutely. There's a clear-cut guideline on that.
Stop sharing slides.
So this looks like an interesting question. Can we prescribe both leupride and Dynogest together in a 40-year-old with severe dysmenorrhea and chocolate cyst removed?
Dr. Naren, you can name the doctor who's asked that also.
Seema Tripathi.
Yeah.
Can we prescribe subcutaneous leupride and tablet Dynogest in a 40-year-old with severe dysmenorrhea, endometriosis and USG, chocolate cyst removed, but still having severe dysmenorrhea, which turned out to be a routine prescription these days?
If I can take that question, the GNRH would bring down the estrogen level, the Dynogest to do the same, but having a little, maybe a less suboptimal estrogen threshold. I don't know why you would combine both, because GNRH would bring an immediate. You can follow GNRH after 2-3 months with Dynogest. That would be one option which some people would do. But starting both together to expect a exaggerated response would be ill-founded. I do not find any justification.
And she's 40. I would go for Dynogest rather than go for leupride or GNRH, because she is, as it is on the menopausal threshold. Osteopenia will be my big worry there.
And I think goserelin would be a better choice than leuprolide. I think there would be that would be agreeable to most.
But tell me one thing, there's a question which comes out from here. Now, refractory to, I've had a patient who just would not respond to anything. I tried cabergoline also. I tried letrozole, and elagolix was not available that time. I don't know if any of y'all have experience with mifepristone or any of the other drugs, but nothing worked, and I had to do a TH-BSO of this young girl, and of course we froze the ovary, of hers. But this is, I think, Seema is talking about a patient who is totally intractable. So maybe if
she's 40, so 40, you probably can think of a hysterectomy.
I have one suggestion, that this lady could be having adenomyosis.
Yes.
That is the reason why.
What about LNG?
And these patients can respond wonderfully well. I give initially
LNG IUCD.
depot of GNRH analog, and after 6 to 8 weeks, I put the
LNG
IUS, and the expulsion rate is much less with this management. And these patients have done wonderfully well for 5 to 10 years.
Agreed.
One of my patients at the end of 5 years removed the IUCD. She came back after 10 years. She settled beautifully.
So we have another question by Dr.
40 years.
No, 1 minute. Naren, one practical point is, what, I like to give the GNRH with the IUCD, because IUCD takes about a month to settle in. So you give both of them together.
You give it 1 month before or with, both works very well.
So if there is a discussion,
Meenu Vash is asking, Meenuvesh is asking, good results seen with DMPA also. So considering the cost of Dynogest, why shouldn't we give DMPA? And for how long? Dr. Ginny Gupta is asking this. And does Dynogest have a role in deep infiltrating endometriosis?
I think we did mention it, that Dynogest, the role in deep infiltrating endometriosis, no hormones work very well. So Dynogest would have a less effect as we speak. So surgery is the mainstay of treatment for DIE, we know that. But yet in some cases, if there is some symptomatic relief for people who don't want a surgery, that may be enough. So you can give a trial of Dynogest even in DIE, knowing that it may not work that well. So I think there's no harm trying. That would be number one. Number two, I think another question which has come for is about the unmarried lady post-surgery. How do you prevent recurrence? It's come from Dr. Bhumika Pawa. That again, it comes to the LNG-IUS. I think LNG-IUS would be an excellent choice of the different choices which we have in case post-surgery for an unmarried girl who is deferring her fertility and is not planning to get married anytime soon. Dr. Narendra, would you like to add? Would LNG-IUS vis-a-vis daily use of Dynogest for preventing recurrence in a surgery, post-surgery in an unmarried girl for endometriosis?
We can try it out. But if it is adenomyosis was there, if it is the uterus was bulky, it will work better. If the surgery was for endometriomas, it will still work, but not as better as adenomyosis. But yes, we can try it out.
She should do very well with Dynogest, I feel.
She will do very well with. And DMPA question we did not answer. DMPA versus Dynogest. DMPA will cause weight gain, depression, and irregular periods. So that would be a worrisome side effects rather than Dynogest, which is lesser, no weight gain, no depression, so no anti-estrogenic. So I think Dynogest, the cost, they are comparing the cost, but I think Dynogest is a labeled drug for endometriosis. DMPA is not a labeled drug for endometriosis.
You know, even LNG in a fertile patient, it causes a lot of atrophy of the endometrium. So the patient takes a very long time to come out. So that's why I would not prefer LNG IUD in a young patient who wants fertility.
It does not take more than about 2 months for the endometrium to return.
So an interesting question is here from Dr. Mansi Patnaik, 39-year-old patient, laparotomy for acute hemoperitoneum. But it was found to have a grade 4 endometriomas. She did probably for an ectopic and it turned out to be grade 4 endometriosis. A ruptured endometriotic cyst probably.
I think
did she do the beta HCG? Because
I don't know, she's not written that. So if she's already opened, found blood, wash away all the blood, do a good endolysis. If you have endometriomas, treat that. Whatever endometriosis is there, fulgurate it, burn it, and put in a drain, wash it, and just come out and start her on Dynogest. My treatment would be that.
Definitely do a beta HCG because you can miss.
Obviously, yes. Pregnancy of unknown origin, unknown location. Yeah. It could be somewhere where you have not even thought.
Exactly.
Dr. Asha, this is the question from Dr. Amar. This is a 25-year-old lady and who has a recurrence after 1 year of surgery of lap cyst, a 7 into 6 centimeters endometrioma again. In 1 year after surgery, how would we manage here?
This is happening quite frequently. Huh?
Is she married?
No, they are married nulliparous. Dr. Amar, married nulliparous is the lady which he has mentioned, and it's a lap cyst done a year ago, and there's a recurrence of a 6 into 7 centimeters endometrioma. How do you handle such a situation?
How old is she? 27.
Yeah, 6 into 7 centimeters.
27 years. And
25.
25. We should look at her AMH. If the AMH is good, I still do not see why we cannot do a repeat chocolate cystectomy and then go for IVF. This is one option. But on the other side, now more and more, there are a lot of papers which say that there is no need for a surgery. You can go in for a ART directly without doing a repeat chocolate cystectomy.
So it is a big one. It is a big one. Probably may require a second look laparoscopy. Probably yes. So we have to weigh our weight very carefully, clinically, fertility, AMH, everything, and then decide, individualize. There's no standard treatment for this.
There
is a case by Rangelakis, bilateral endometrioma in adolescent young girl, how to manage. Bilateral large endometriomas.
Medical therapy, if possible, as far as long as possible. If she has pain or something, if it's symptomatic, then surgery would be the answer.
If medical treatment does not work, yes, you have to do surgery because you don't want to damage her ovaries permanently. So yes, you might have to resort to surgery even in adolescent girls. So Dr. Shakre Truppa, is it possible to do ovulation induction without surgery? Yes, we discussed that. Small endometriomas, yes, you can do ovulation induction and combine with IUI also if it is simple, small unilateral endometrium. Why not do stimulation protocol and egg embryo preservation prior to surgery? Dr. Raj. Dr. Nandita has already discussed this. Yes, this is a very good idea of egg pooling repeatedly and then embryo preservation, make a good endometrium and then do an IVF. That will give you the best result. Management of recurrent painful endometriosis in a female 35-year-old who has had surgery, medical treatment, now completed her family, Dr. Neelu Khaneja. 35-year-old, intractable pain, completed family. And as Dr. Nandita said, sometimes you have to go and for a radical surgery even at younger age group. So if nothing works, that is your last resort.
Can I add something? You can really do something for her. Freeze her ovary.
Freeze the ovary. 35, completed family. She doesn't want.
Completed her family.
You never know.
Completed her family.
You never know. You never know. Correct. So which is better, a cystectomy or a cyst aspiration, Dr. Amita Nanda? Cyst aspiration or cystectomy?
Primary surgery, cystectomy is always better. Recurrence rates are very high with aspiration.
See, if you put in a laparoscope, do a cystectomy. Then doing only aspiration, if your scope is in, I don't think it is right. If you want to plan a cyst aspiration, do it ultrasound guided. Don't put in a laparoscope just to aspirate the cyst.
Yeah, what is the role of ultrasound guided aspiration today?
It's very simple. We can do it if you want, but only for recurrent large ones. The spill can occur. The spill occurs. Infection can occur. And all those things are there.
Yeah, there is definitely occasionally there is a chance of ovarian abscess, which has happened to many doctors. And after that, they will never again do the aspiration.
So personally, I have tried. I have washed the cyst nicely with saline, and I've injected escarole in it for causing. So, and it has worked, and it has not worked also. So the cyst is refilled in 1 month, and for some, it has not even refilled in 2 years. So we are not sure. There's no evidence whether it's going to work or not. It's your personal experience. We need a large study to know whether such treatments will work or not.
Yeah,
yes,
we had done a lot of cases earlier, 10 years back, of vaginal cyst aspiration. Give them a injection Lupride depot, and you see the regression of the cyst, and later take them up for IVF. But at the end of 10th year, one finds ovarian abscess.
Yes.
After the ovarian abscess, we stop the procedure completely. One ovarian abscess and then no more aspiration.
And then you will never do it.
Naren, even we had this problem. We had an ovarian abscess.
I know about that case. I know you discussed it.
South Africa. But this treatment is now coming back, and they're using sclerosing agents. And sclerosing agents have shown not to have an effect on the AMH. AMH has also been measured after doing this.
Because it's sclerosing only the internal lining, and these sclerosing agents, the surgeons use it intravenous, everywhere they use it. So it's very, very safe. So it's very, very safe, and we have now got a good amount of 40-50 cases. I'm just compiling to publish it.
Okay.
Let's see how it comes.
And if it works well, then chocolate cystectomy will be out.
I don't know. I don't think so. Patient having menstrual problems with Dynogest, kindly explain the amenorrhea. Since 2 months, pain is relieved, but is starting now recurrence even on Dynogest. What should we do, Dr. Sangeeta?
Sorry, what?
So with Dynogest also recurrence is occurring after amenorrhea of 2 months. Again, the pain was relieved, but it's coming back now.
There are some patients who are refractory to it, and you can't really do anything about it, and you need to try other medications. As I said, cabergoline, elagolix.
Cabergoline, letrozole,
and how important is it to change the brand of Dynogest?
Yeah, so that's the question always which comes when you write a good brand, then it always says the same tablet is available for half the cost.
Yeah, that's right.
Now, when something is available for half the cost, there must be some difference.
Yep.
And so I don't know. I mean, there has to be a case-controlled study on brands, comparison of brands, and I think that is needed. But I don't know.
Yeah, and also I think increasing the dose. I think, as Dr. Nandita said, yes, sometimes you do increase.
You can go up to 4 milligrams. You can go up to
4 milligrams. Very well accepted. Yes.
You can go up to 4 milligrams. So I don't have any other question on my Zoom. This thing. Anyone else has?
No.
No, I think that was the last question.
So, Dr. Asha, you can conclude.
Yeah, I think we had a wonderful lecture by Dr. Narendra Malhotra, which said a lot about medical management. And later we had very nice case discussions by Dr. Nandita, Dr. Basap, and lots of questions. So we all know that endometriosis requires a lifelong management plan because it's a chronic disease. So how many times can we do surgery for these women? So it's always medical management that has to be the mainstay of management, and trying to avoid surgery as much as possible. So try as much as possible medical management rather than surgery.
One more question has come on imaging versus ultrasound versus MRI. Well, ultrasound is good enough. Ultrasound can diagnose even adenomyosis with 3D, with contrast, now with everything. Where see if the lesion is less than 5 millimeters, small lesions, then they cannot be picked up by even MRI. So I think ultrasound, transvaginal, transrectal, with or without contrast, with or without gel. For adenomyosis, the endometrial myometrial junction, we now put in the gel in the uterine cavity also and then scan. So ultrasound is your number one. MRI, if you're not very good, you do not trust your sonologist, you're not doing your own ultrasound, then maybe MRI. But MRI is expensive, does not give you anything additional more than ultrasound.
Yeah. Any concluding remarks by Nandita?
No, I think thank you very much, Asha. It was really beautifully organized, and Beer, I think Deepak, I must thank you enough for having done this whole program. And Basab, it was great fun coordinating, though, I'm missing the personal touch totally. Being there, having each other. Except that we'll have to be with masks. As
I know.
But thank you very much, Asha. It was really wonderful and really enjoyed it. And I think Subbu and team Science Integra did a wonderful job. So
on behalf of Endometriosis Committee, I thank all my speakers and also thank the Vision team for the wonderful technical support and for having put this thought of making this program.
Thank you. Thank you, everyone.
Thank you, audience. Thank you.
Thank you. Thank you.